Yes, I am.
So, good evening once again. It's the usual time of the month for all of us to get together. And now we have started with grand rounds where we have a keynote and we discuss the challenging cases. I'm going to pass on the podium. It's not really podium. I'm going to pass on the show to John, Rima, and our efficient team at the Education Committee, which are leading this and taking it forward. And I think we have two announcements to make. Inflammatio, 21st and 22nd of November at Singapore. And then Bruges course, which is an alternative to Venice course and which will be held June 1st week. We will pass on the information to all of you very soon. Bruges especially has very limited slots and would be on first come, first served basis. Thank you very much, and over to you, John.
Good. Well, welcome everyone to our Uveitis Grand Rounds. This is our 8th installment, and today we're going to be talking about ocular syphilis, which when I was trained, everyone said, oh, it could be anything, and there aren't really any very distinctive factors, but I think times have changed, and now you can learn a lot about recognizing ocular syphilis. So let's proceed. I think Rima will introduce.
Thank you, John, and we welcome you all. So we start the IUSG Grand Round on Ocular Syphilis with the keynote lecture on practical tips in the management of ocular syphilis by Professor Mark Westcott. Professor Westcott is a consultant ophthalmologist in Muffield Eye Hospital NHS Trust, also an adjunct professor in UPMC Pittsburgh. So welcome, Professor Westcott.
Okay, thank you, Rima. I'm just sharing the slides. Here we go. Can everyone see that? Hopefully,
yes.
Good. So thanks for inviting me to give the lecture. I don't have any commercial disclosures, so we're going to talk about ocular syphilis today. This is a sexually acquired infection. It's a spirochete, and we see a lot of cases. We've seen a great resurgence of this disease in certainly the UK, Europe. I'm talking for the US, and I suspect Asia as well over the last 10 years. I'm going to show you some manifestations and also some tips as an ophthalmologist with an interest in this. So if you're interested, it has a fascinating history. There's plenty of publications about the history of syphilis in general. These are all characters from history who are alleged to have syphilis. You can try recognizing them. On the right is a Hogarth painting. This is London in the 17th century. These are ladies of perhaps ill repute, and there are stigmata of syphilis in this wonderful painting. Maybe some of our current politicians should be tested for this disease as well, but we won't get into that anyway. The kind of medical student classification of syphilis is very rigorous. We've got primary, secondary syphilis, latent. And typically it's said that if you're going to see ocular syphilis, as in ocular inflammatory disease, it's going to be in the secondary stage. But it's a bit more complicated than that. And this is a more kind of conventional modern approach that there is overlap between the stages of syphilis. But the bottom line is that in terms of ocular syphilis, you can get CNS invasion fairly early on after infection, almost at the primary stage, and certainly at the secondary stage. So this kind of middle right panel is where we're going to see syphilis uveitis, okay? Some of these patients will be sick. They will have the systemic features of secondary syphilis. And at the bottom, you'll see what's called tertiary syphilis. I'm not going to talk about these ocular manifestations, but these are the patients that you might see 20, 30 years later in a neuro-ophthalmology clinic. They won't have signs of active inflammation. They'll have a pale optic nerve. They may have a pseudo retinitis pigmentosa type pattern. So I'm going to be talking about active ocular inflammation in syphilis, okay? And we know that the typical stages that there is overlap. We're not going to undress our patients in clinic as ophthalmologists, but this is an example of a macular-papular rash. But we can look at the hands, and patients come in and they put their hands palm down on the slit lamp. But I've certainly diagnosed or been suspicious of patients with ocular syphilis just by turning their palms over and seeing the rash. So this is the macular-papular palmar rash that should set alarm bells. So we mustn't forget we should be general physicians to some degree as well. This is something that I want to stress for residents and non-experts, that it's not unusual to have hearing loss in active syphilis. These patients can get an acute sensory neural hearing loss, and they can present to us first with uveitis. So if you see a patient with active uveitis and sudden onset hearing loss, you must think of syphilis. I have listed a kind of differential of uveitis and hearing loss. We've got VKH, Lyme disease, if you're in Lyme endemic areas. Sarcoid can do anything. Sussex, which is a pretty rare disease, and granulomatosis with polyangiitis. But we should certainly think of syphilis, patients who present with acute hearing loss and uveitis. What about the overall epidemiology? This is a disease of men. Overwhelmingly, and that certainly it applies to the UK, Europe, US, and Asia. But it is on the rise both in men and women. This is data from the UK, but European data would be very similar. And the top line shows a steady rise of cases. The black line are cases in men. This is just overall syphilis, not syphilis uveitis. Much rarer in women, probably 8 times rarer in women. But you can see there's an overall gradual increase. So we're going to see more of this. Who gets it? I mean, syphilis uveitis is overwhelmingly a disease of men who have sex with men. And this has been shown study after study. This applies to syphilis in general, and certainly syphilis uveitis. So again, this is some UK data, but it would be very similar from many parts of the world. The top line is the sexual kind of orientation of patients, men who have sex with men. The second line is men who have sex with women, much less common, but we are still seeing a little bit more, and it is on the rise. What about ocular syphilis? There's much less data. I know John Kempen has a great interest in epidemiology. There's very little data or good data on the epidemiology of ocular syphilis. Most of it's single center case series, but we did do a study about 10 years ago, which was called the BOSS study. The British Ocular Syphilis study was published 10 years ago. And this was a national prospective, rigorous epidemiological survey of the manifestations of ocular syphilis. I'm going to show some data from this, still valid today. So this was the first prospective national survey. It was done in the UK over 3 years. And the idea was to characterize the demographics and the incidence, and to look at some of the presentation patterns of this disease. We're talking about ocular syphilis, and some outcomes after treatment. The case definition was pretty simple. These patients had to have active intraocular inflammation with positive treponemal serology, with the exclusion of clearly other disorders. We did not look at late syphilis. So again, I'm parking late syphilis down the line. These are burnt out kind of neuro cases, but these are patients who have active eye inflammation. And these are some of the results. We had 41 cases. The incidence was about 0.3 per million per year. Again, far more common in men. The men outnumbered the women by about 9-1. Here is an age distribution of our patients. And this was a surprise that it has quite a broad age distribution. So we were picking up syphilis uveitis in patients in their 60s and 70s. And again, I want to stress this is not just a disease of young people. So but for residents or others, please test everybody of adult age. You can see females were far, far rarer, but I must stress that this is a very broad age distribution of presentation, okay? How well did they do? They did remarkably well. 92% or over had decent logMAR visions after penicillin or antimicrobial treatment. About a third were HIV positive, and some of those were newly diagnosed. So the ophthalmologist at least referred to physicians with a new diagnosis of treponema and HIV. And the other interesting feature, which I think is almost unique for this disease, that didn't matter how bad the vision was or how long the patients had symptoms, they all did broadly just as well. So very treatable, and the presenting vision didn't seem to influence outcome. This was the classification based on our data of where in the eye you had the inflammation. The overwhelming majority have a panuveitis. Some have optic neuritis. The interesting feature for me is that this is quite rare to see a pure anterior uveitis that's caused by treponemal disease. So if you're a resident and you see a patient walk in with a sole anterior uveitis with no evidence of any intermediate or posterior uveitis, it can be syphilis, but it is uncommon. Syphilis normally causes middle or back of eye problems, okay? So this was the summary from our publication. It was a disease of men. You must consider HIV infection. It seemed to be a normotensive uveitis. Anterior uveitis was quite rare to present in isolation, and posterior uveitis was common. And also that they did very well with treatment. And I'll touch on some of the treatment. I'm going to just touch on some of the phenotypes. I'm sure we will show you some examples in our case discussions, but I'm going to just show a couple of slides because time is tight. But one particular feature is what's called posterior placoid chorioretinitis. Here's an example, 47-year-old male, previously fit and well, 2-month history of poor left vision. And these are the color pictures. And what I want to highlight is this kind of dusky discoloration that's kind of well circumscribed. You can pick it up quite easily on the colors. It's clearly at the level of the choriocapillaris RP. Very characteristic, these large plaques, usually at the posterior pole. The eyes are often quite quiet. Here's another case, 45-year-old male, fever, 5-week history of cloudy vision. The autofluorescence is quite striking. So you get these extensive confluent hyper-autofluorescent patches. Posterior pole, macula, can involve around the disc. Some inflammation here. He had AC activity and some vitritis. So this is posterior placoid, very characteristic phenotype. Here's his OCT, scans through the macula. You have these very unusual, I'm trying to highlight them with my mouse, sub-RPE deposit, kind of conoid deposits. And there's profound disruption and feathering of the ellipsoid. So this is why the acuity is very poor. Very few diseases will give these unusual appearances. I mean, maybe lymphoma, maybe Lyme, but it's fairly characteristic. And this is how the patient did. So here we have some scans in November, these loss of the ellipsoid, these sub-RPE deposits. And this is a few months later, post-penicillin therapy. So you get recovery, restitution of the ellipsoid, and recovery of vision. You can see the scan normalizes to a large degree. So this is treatable. Okay, let's show some other phenotypes. And I'm going to be brief here. I suspect it will be covered in some of our presentations. Syphilis can cause retinitis, and it can very easily mimic acute retinal necrosis. Here is a patient came up to Moorfields A&E, had peripheral retinitis. You can see white spots on the retina. There is a little bit of vasculitis. Not unreasonable to treat this patient as ARN. I mean, you know, I challenge any world expert in the world to say this definitively treponemal versus acute retinal necrosis. He was tapped, virology taps were negative, and lo and behold, his treponemal serology was positive. So this is treponemal presenting as acute retinal, as a peripheral retinal retinitis, okay? So it can mimic ARN. Here's another slightly less common phenotype. It's very unusual. I call it funny white dots. It was described maybe 10 or 15 years ago. Some people call it an inner punctate retinitis. And here is an example. This is from the publication. You get these peculiar nummular foci, probably inner retinal, the kind of junction between the vitreous and the inner retina, presumably collections of inflammatory cells, maybe even treponemal organisms, sometimes with some fluid. Very unusual appearance. Very few things going to mimic this. And then just to show you another example, treponemal disease can certainly cause an optic neuritis. Here's an example, 48-year-old male, HIV positive, 2-month history of hearing loss. So I've emphasized the importance of assessing other symptoms. So syphilis can cause an acute sensory neural hearing loss. His vision is down in the left eye. Here's the color pictures. We can see that there is swelling around the optic nerve. There is a suggestion of something happening in the left eye as well. Here is the angiogram. We have some subtle disc leakage. And in the other eye, there's some very subtle diffuse RPE leak. And this is a practice point that I find again and again, that treponemal can do different things in each eye of the same patient. So not unusual for a patient to present with a hot disc on one side and maybe a little patch of retinitis in the fellow eye or a placoid. Very, very few diseases are going to give different phenotypes in the same patient between the two eyes. Again, this is very characteristic of syphilis. So this is a practice point. Okay, we're going to try and make sense of some of serology here. This is a graph of our serological testing. Remember that we must use treponemal-specific serology. So we've got the fluorescent treponemal antibody absorption test. It's quite expensive. We tend not to do it too much, but we've also got the TPPA, the treponemal plasma hemagglutinin test. So these are the tests up here. These are very sensitive, very specific, and they'll start to rise after maybe 4 to 6 weeks of infection, and they stay positive through life. So regardless, whatever happens to the patient, treatment or not, by and large, they're going to stay positive. The physicians are going to use indirect tests, which is primarily the RPR, the rapid plasma reagent, or the VDRL as an infection titer, as a marker infection. So hopefully with treatment, these non-specific tests of syphilis will decline. Okay, so these are not specific tests for syphilis, but they're used as a marker for infection. Primarily, we're going to be seeing our patients with our syphilis uveitis in our sort of secondary kind of period. I have said that there is some blurring between these categories, okay? If nothing happens, patient maybe doesn't get any treatment, he will go into the tertiary stage. And at this point in time, the treponemal serology will remain positive. The infectious markers will be very low, but the patient will have latent or tertiary syphilis. These are the patients going to present to our neuro-ophthalmologists or our geneticists with kind of pseudo-retinitis pigmentosa pictures or pale optic nerves. So what about treatment? These are some validated treatments. These are going to be undertaken by our GU physicians. If we have a patient with ocular syphilis, we would tend to give 2 weeks of IV benzyl penicillin. If that's practically not possible and we have stretched healthcare systems, you can give intramuscular megadose of procaine penicillin with probenecid. The probenecid increases the antimicrobial load. You can use ceftriaxone intramuscular or intravenous as an alternative. Some patients are going to refuse this. They don't want admission. They don't want daily intramuscular injections. So amoxicillin can be used with probenecid for patients that will refuse this treatment. But by and large, they're going to get megadose of penicillin, IV, IM. What do you do if they have penicillin allergy? Well, the CDC have recommended ceftriaxone with a history of penicillin allergy that's historic. It's a very, very low risk of cross-reactivity with ceftriaxone. So it's probably going to be safe. You can do some skin testing before you commence therapy. Some guidelines recommend penicillin desensitization, but it's not very practical. It's expensive. It takes time. So that's not going to be a very useful option. And there is some limited data about the use of doxycycline for penicillin allergic patients, but we have much less data. So my preference probably would be ceftriaxone. This is something that is sometimes debated, is do you need to do a lumbar puncture for CSF analysis in ocular syphilis? Well, the answer is no. For ocular and or otic syphilis, as in sensory neural hearing loss, it doesn't change your management. It's very rarely useful. There are times where you might want to do an LP. So this would when a patient might be presenting with cranial nerve palsies, as in acute palsies with uveitis. So this patient has not only uveitis, but some other acute neurology. The other indication might be if the infection titers fail to normalize after treatment. So the patient gets his intensive systemic treatment and the RPR titers still remain high. This would be of concern. And this would be a very rare indication where you might consider an LP would be ongoing or worsening eye signs despite inflammation, and inflammation despite treatment. So we've got a patient with uveitis, you've given him the full course of treatment, he's being compliant, and he still has ongoing worsening eye disease. This is actually, in my practice, very, very rare. You need to consider reinfection, but you may want to consider a CSF analysis to see whether the organism is still there. So this is, the reality is you don't have to do an LP in your ocular syphilis cases. And this is in accordance with UK, European, and CDC guidelines. Okay, what about the role of steroids? Well, we worry about the Herxheimer reaction, which is effectively a cytokine storm. It was the first described cytokine storm. And there is dogma to use oral prednisolone. Typically, the patient will be commenced on this reasonable dosage, about 30 to 60 milligrams of prednisolone, 3 days, and you'll start the antibiotics, you'll start the penicillin 24 hours after commencing the steroids. And, you know, excuse me, it makes sense to use this to prevent worsening of your panuveitis, of your optic neuritis. There's very little evidence that we need to do this, but typically we would tend to do this, okay? And just my own view of the role of steroids in terms of treating the ocular disease, and I suspect this will come up in some of the discussion, maybe some of the case presentations. This is my own non-evidence-based kind of experience about the role of steroids. We're talking about a patient with confirmed syphilis uveitis where they're starting antimicrobial penicillin therapy. If they have severe anterior uveitis, clearly I'm going to give them intensive topical steroids. I would also give that for vitritis. I rarely need to use oral for that. The posterior placoid cases I've shown you, they often don't have a lot of inflammation. I typically might give them some steroids to avoid the Herxheimer reaction, but I tend not to give them a lot of oral steroid because they seem to do very well just with the antimicrobial therapy. Again, the retinitis seems to improve dramatically once they start therapy. The signs melt away in a week or two. I may well give them intensive topical, but I rarely need to give them systemic steroids. Might sometimes if they have a lot of vitritis. And again, for optic neuritis, I historically do. There is dogma for me to do that. But again, there's no evidence that these patients need steroids other than treating the Herxheimer reaction for optic neuritis. Again, they seem to do well with antimicrobial therapy. Okay, so these are the key points I just want to stress, that this is a worldwide disease. It's much more common in men, and the risk factor is men who have sex with men. It's a disease of men of all ages. but we are seeing some rising rates in other groups. Hope I've shown you some of the very diverse clinical presentation. We must keep a high index of suspicion in all our patients. I have a very, very low threshold for testing for this disease. I've shown the various phenotypes, use sensitive serological tests, and the prognosis after treatment is often excellent. For those interested, this is some guidelines. We've published a major review on syphilis, and some of the panel of co-authors. It's an excellent review, highly recommend it, published in Ocular Immunology and Inflammation. And these are some European guidelines on the management of syphilis from the medical perspective, and there's also some very good and detailed British guidelines as well. And I think that's all I'd like to. This was just a curious poster for public health that kind of made me laugh, and these are some historical figures alleged to have syphilis. This looks like California to me, but it made me laugh. I'd like to acknowledge some co-authors, Rashmi Matthew, who was my co-worker in the BOSS study, Sunita Umar, who gave me some very helpful tips on the physician side of things, Bengo, and Superwatt, who's my fellow at Moorfields. Thank you very much.
Thank you, Professor Westcott, for this wonderful covering all the points in the diagnosis and management of ocular syphilis. We have some questions for you in the QA section. So with this, we thank you very much. And we now move on to the case presentations of today's webinar. So we start with Professor Ahmed Salam, who's from University of Arkansas Medical Sciences, Little Rock from Arkansas. Welcome, Dr. Salam. And we'll be having his fellow presenting a case on placoid chorioretinitis by Ahmed Shakarchi. And this will be followed by a discussion by Professor Salam.
Yes, hi. I'm sorry. Sorry for the difficulty in logging in here early. Thank you so much for the invitation. I enjoyed Professor Westcott's talk. It's beautiful. And Dr. Shakarchi now is going to present a case of syphilitic retinitis, and then we can have the discussion after. I think he's in.
Morning. Thank you for the opportunity. I have a couple of cases to present, so let me just try to get my screen shared here. Right.
And we're conscious of the time, of course, Dr. Bensal, so let us know if we're exceeding with time.
So here's a first case. These are cases that I did my residency at the University of Arkansas. So these are cases that I had seen on call as a resident. This is the first patient who came in with what looked like retinitis. His vision in the right eye was 2200. He had history of gastric ulcer, brain bleed, and then he presented with this picture. We see, in addition to the area of retinitis, that there is this placoid area of hyperautofluorescence in the posterior pole. On the OCT, we can see, this is peripheral OCT showing definitely blurring of the retinal layers.
I'm sorry for interrupting. Is there a problem with my screen, or is it too magnified? Because I can't see the images. Is it happening to others also?
We are able to see the images, Dr. Bashar.
Okay, perfect. Go ahead. Sorry, it's just me.
Okay, all right. There is also cells in the overlying vitreous, and which doesn't give us a clue to the diagnosis, but in this case, the clue was the posterior placoid hyperautofluorescence. Here is the patient tested positive for syphilis and responded to treatment. Here is a second case. This patient was a 42-year-old female, was referred for papilledema evaluation, but she had cells in the anterior chamber, and that other patients with disc swelling in our institution gets tested for syphilis due to its high prevalence here, but this particular patient had cells in the anterior chamber, so we definitely tested them for syphilis. It was positive, and we can see there are a few cells here in the subretinal space. On the OCT, we see that there is disc edema extending to the subfoveal space. Case 3, this is a case of dense vitritis. We can see some hyperautofluorescence placoid pattern as well as speckled autofluorescence in the periphery. Right eye, the view, it was hazy in this case. This is a patient who had history of neurosyphilis in the past that was treated. And then on the OCTA, we see that there was attenuation of the choriocapillaris, which is a highly characteristic finding of syphilis. And this is one of the things that are reversible in syphilis with treatment. This is the same patient 2 weeks after treatment. We see that the vision improved. There is still some vitreous haze, but the vitritis is definitely has improved and the vision is improved as well. This is the 4th case. This is a patient, history of treated syphilis again, history of CMV retinitis back in 2016. But after the treatment of the CMV, his vision had improved to 20/40. And then they presented with this finding. Again, we see attenuation of the outer retina in the right eye. There was, I'm sorry, give me 1 second. There was another slide that I think is relevant to this. So we have old pictures of the CMV retinitis. We have a picture of the retina after the retinitis. The CMV retinitis had resolved. He had macular edema associated with the CMV retinitis. And then now, we have documentation of attenuation of the outer retina, and that prompted the retesting for syphilis, which came back positive. The patient was treated. I won't belabor this because Dr. Westcott just went over the serological diagnosis of syphilis. I was going to say that here in the United States, we've moved from testing for RPR first, and here we are testing with a treponemal antibody test first, and then using RPR or VDRL as a confirmatory test. If there is high clinical suspicion with a positive treponemal test, any negative RPR, we typically retest the patients with another treponemal antibody test, and then if that's positive, then we typically go through a therapeutic trial. This is based on the CDC recommendations. And again, Dr. Westcott just went over the syphilis treatment, and then again, this was somewhat controversial, and people have different preferences regarding steroids. Like Dr. Westcott said, we typically put patients with a significant AC reaction on topical steroids, and we typically, unless there is a contraindication, we give patients a 2-week course of oral steroids, 40 milligrams, medium dose, 2 days after starting the treatment for syphilis. These are the cases that I have. I don't know if Dr. Salam wants to add some important points to the discussion.
Thank you, Ahmed, so much. This is an amazing collection of cases. And I think Ahmed finished with what we do in Arkansas. We have lots of cases in Arkansas, and we've published recently a big series. About maybe 10% of our uveitis, I think, would be like syphilis cases. So what we do is for any uveitis affecting the posterior segment, we give them IV penicillins unless they significantly reject. Usually it's not the case. They get admitted, and sometimes they send them with a PICC line home to continue with the rest of the treatment. Very few number of cases get treated with high-dose intramuscular penicillin, and all the patients, unless there's a contraindication, get 2 weeks of oral prednisone, 40 milligram per day, with a sudden stop because it's only for 2 weeks. And that's our regimen. Thank you. Any questions, Dr. Bensel, or do you want me to comment further?
Yeah, we'll take up the questions in the end of the webinar. And any more discussion by you?
I think, I really enjoyed the talk of Dr. Westcott. It was a very nice broad cover of syphilis and what happens in the syphilis world, and the cases by Ahmed were great. I think My discussion point is especially if you practice in an area where syphilis is on the rise, and I think it's on the rise everywhere, given the urbanization and some change in cultures and happening. So I think be wary of syphilis. That's my number one thing. Number two, how to suspect syphilis, and I think there are like certain features you need to be aware of. For example, if you have a patient who has certain characteristic feature like placoid lesions, whether in the macula or elsewhere, a lesion that looks placoid, that is suggestive. And second, you have to consider it in every case that you're thinking this patient has acute retinal necrosis. So Dr. Westcott showed beautifully the case of suspected acute retinal necrosis, and that's what we do. If you suspect acute retinal necrosis, we take an AC tap, we do an usually intravitreal foscarnet, put the patient on high dose oral valacyclovir and get bloods for toxo and for syphilis in everyone. And then we send the aqueous tap for viral and toxo PCR. And I think doing this, you're covered on this category where you have a patient presenting with acute retinitis, which is unlikely, like in this case, being Behçet, and you're thinking along the line of infection disease. And I find retinitis, it's an easy differential diagnosis, because if you're not dealing with Behçet and maybe just keep lymphoma at the very back of your mind, then you're definitely dealing with infection. And then there can be toxo, syphilis, viral, and very unlikely fungal presents as retinitis. So I think that's on the retinitis part. So the placoid part, the retinitis part. And the other thing, these things presenting with the optic nerve. So optic nerve with uveitis, I would be thinking as well of syphilis. Then there are other things to keep in mind as well, uveitis and joint problems and rash. Again, syphilis is on the rise, uveitis, and there is a history of multiple sexual partners, or very importantly, MSM, men having sex with men. Again, syphilis should be on the highlight. So I think these are my groups where I'd be thinking of syphilis. And then Ahmed touched on the difference between UK and US practice. I practiced in the UK before. We test the other way. We test with immunoglobulin with syphilis IgG, and then after that we go for the RPR.
Thank you. So from what I got here, you said you give steroids for 2 weeks, 40 milligrams, and then stop abruptly.
Yes, yes, correct. I mean, my experience, and again, discussion with physician, also what happened in the optic nerve treatment trial before, you need more than 2 weeks to suppress the pituitary adrenal axis. So if you give for 2 weeks, you can just sudden stop, and that's what we do. And we use that regimen for, sometimes like to cover cataract surgery in uveitic patients and other things. I just find that regimen a handy regimen that we adopted over the last 10 years.
So thank you very much for the wonderful cases.
May I just make one? Yeah, just to confirm that certainly in the UK, we don't use the VDRL or the RPR for primary diagnosis. We don't use for screening. We do use the treponemal serology, so the TPPA or the fluorescent treponemal antibody absorption test. Some centers use the syphilis IgG, IgM, but that's not very reliable actually. So I wouldn't use it for screening, but we have very sensitive treponemal serology, which is specific, and the VDRL RPR is purely just for monitoring infectious load, and it's completely non-specific anyway. So I just want to make that point.
Thank you.
So thank you very much. With this, we now move on to the second set of case presentations, which is going to be a typical case of syphilis. And for this, we have Dr. Francesco Picci from Cleveland Clinic, Abu Dhabi, and his fellow would be presenting the case, and Dr. Yanni Perez Jimenez, followed by discussion by Dr. Francesco.
Thank you very much, Rima. So we were asked to present the case of typical syphilis. So Yanni, take it away, and then I will comment the last slides of Yanni.
Sharing? Is sharing right now? Okay. So good afternoon, everyone. My name is Yanni Perez Jimenez. I would like to say thank you, ICU, and my mentor, Dr. Francesco Picchi, for the opportunity to present this case. So let's moving on to the case. This is a 52-year-old man from Pakistan, referred to ID to eye clinic for present decreased vision in the left eye for 1 month, associated with pain and redness. The patient was treated for an outside ophthalmologist with cyclopentolone, prednisolone 3 times, and tobramycin plus dexamethasone drugs in the left eye without any improvements. The review of systems denies, past ocular history denies, previous medical history was a hypertension, chronic kidney disease, hepatitis B, and the patient was treated with amlodipine and perindopril, no allergies, no social history. So moving on to the evaluation, the best correct visual acuity of OD was 20/25, left eye 2150, IOP within normal limits, PPL equal, a full external ocular movement, no APD. The evaluation of the anterior segment shows OD unremarkable, left eye cornea with pigment deposits, anterior chamber 3+ cells, no flare, iris irregular, lens with pigment capsule, and bias score 3+ in the left eye. The fundus eye examination in ultra-wide-field fundus photography of OD was within normal limits. The left eye shows 3+ vitritis, that is superior nasal, a faint area of retinitis surrounded with some ground glows and some white tops superior deletions. The periphery of the left eye was we don't find another lesion. So right now we are thinking about a potential retinitis unilateral the left eye. So we are thinking can be possible related with viral, tuberculosis, syphilis, CMV retinitis, progressive outer retinal necrosis, or acute retinal necrosis. Excluded that the patient doesn't have any immunocompromise, we exclude CMV retinitis and progressive outer retinal necrosis. Nowadays, we count with the multimodal imaging, so we perform OCT on OD was within normal limits. The left eye showed hyperreflective dots correlated with the vitritis and macula without fluid. The OCT at the lesion shows some hyperreflective dots overlying the posterior gyloid, and at the same time, the RPE changes that are suggestive about syphilis. The fluorescent angiography of the OD was unremarkable. The ICG was within normal limits. The left eye, the met phase shows a hot otitis with an area of leakage related with vasculitis and some areas of leakage superior nasal related with the retinitis area. With the pass of the angiogram, the fluid increase, more area of leakage. So the ICG was within normal limits. When we are thinking about potential cause, we used to work with traditional algorithms. So the patient underwent with RPR, FTA-BS, quantiferon TB for exclude TB, toxoplasmosis IgG and IgG antibody, and HIV. Where we are thinking the potential cause, we started empirical treatment with sulfamethoxazole trimethoprim, thinking about toxoplasmosis, and valacyclovir, thinking about viral retinitis. So the last results came, and RPA came positive with confirmed with FTA-BS, quantiferon TB gold, and toxoplasmosis and HB was negative. So we admit the patient and started treat the patient with penicillin 3 million units every 4 hours. We include the treatment with this infectious disease, and we complete the treatment at least 10 and 14 days. And we start pre-40 1 drop every 6 hours in the left eye. So follow-up in 48 hours, the patient came with the levels of creatinine high, so we adjust the doses. And at the same time, we start treatment with prednisolone 40 milligrams once daily, because right now the patient is covered with the antibiotic. The follow-up on 40 hours was BCAB 2100, decreased the cells in the anterior chamber to plus, still hazy view, but the area of the retinitis are more pigmented. And the OCT at the lesion, if you saw here, there is less hyperreflective dust overlying on the posterior yellow, still with some RP changes. So the follow-up in 5th August, the visual acuity improved at 20/60, just 1+ cells, less vitritis. And the fluorescein angiography shows that there is less leakage and start to pigment the area of retinitis. On August 11th, the best correct visual acuity was 20/50. There is no less cells, 0.5 cells, and the fluorescent angiography was totally healed, just a little bit stain at the late phase of the angiogram. And on 16, the best correct visual acuity was the same, but there is no cells. We repeat, the RPR was the same, positive, but the fluorescein angiography shows no staining, was totally healed the lesion. There is a little bit hazy view on the ultra-wide imaging because the patient developed a cataract. The area of the lesion is totally healed. So when we compare the OCTs of the baseline, last day was 16 August. After treatment, there is less vitritis and the area of the RP chains are totally better compared at the beginning. So we decided to discharge the patient with oral prednisolone, 40 milligrams, or oral doxycycline, 100 milligrams every 12 hours per 10 days, and prefer twice per day in the left eye. So 1 month follow-up, the best correct visual acuity was 20/60, no cells in the anterior chamber. The area of retinitis was totally healed. So how many types of syphilis reticulosis we know? We are.
So, Yanni, sorry to interrupt you, Yanni. So this is, I just want to comment on this case here. I think there's 2 points here to make. The first one is multimodal imaging that has given us the ability to, even if we know that syphilis can mimic everything, multimodal imaging has given us the ability to put syphilis, typical syphilis, into different categories. And we've just seen a video presentation and comments by Dr. Hamed on the placoid form of chororetinitis or retinochoroiditis secondary to syphilis. But this, we were asked to present a typical syphilis case, and to me, this ground glass appearance, it's the typical appearance that you can see in the back of the eye. So move on the slide, please, Yanni. Because Dr. Mark made a very good point, and we've seen also these are that's the same image that Dr. Mark presented. So the retinochoroiditis, based on multimodal imaging, you can distinguish into 2 appearances. So one is the ground glass appearance, and it's very typically very different from the acute retinal necrosis or toxoretinitis, which is chalk white. This is a different kind of white. You can sometimes see the details underneath. And then you have those deposits that Dr. Mark was mentioning. Those may be posterior keratic precipitates, basically, so inflammatory cells precipitating on the hyaloid or the retina, or might as well be spirochetes. We don't know. I think it was Emmett who described them the first. And then sometimes the case on the right is one of my previous cases. This is something that masquerades as acute retinal necrosis. So here, the first thing you need to do for our residents and fellow who are listening, you need to think of viral and toxins. So that's what we did for our patients. What you need to cover until you have the results back. So in this case, in particular, this case on the right, it's a denser appearance of chororetinitis, and it was actually corresponding to an area of scleritis. So what I did for this patient, same thing, Bactrim 3 times a day and covered with valacyclovir. And then once the results came back, I shifted to IV penicillin. So Yanni, if you can move on to the next slide. So this is the typical appearance that our case is portraying. So this is the retinitis that you can see. It's not very dense. You can, it's mostly triangular, and I'm not sure why, but there must be a reason why it is triangular. And sometimes it has superficial accumulation. And when you do an FA, there's an area of hyperfluorescence at the margins with some vasculitis as well. So this is our take-home message from our case, that you need to always consider syphilis when you diagnose uveitis, of course, but you can try with multimodal imaging to have some patterns in your mind that can guide your diagnosis and your laboratory testing. And they, as we already said, they should be treated as neurosyphilis. And then one thing, yes, that's actually a good point. The RPR, it's always a discussion that I have with infectious disease, because even after 2 weeks of penicillin, our patient's RPR was not back to, did not decrease, was still 1/64. So I asked them to discharge the patient on doxy, and then the RPR normalized. I think it's a point that we can all comment upon. It's just the way I practice, and I discuss it with the infectious disease specialist. And then the use of corticosteroids, I usually wait 2 days, 48 hours. As Dr. Westcott commented, in this case, I use them because there was a lot of vitreous reaction. So I don't want it to consolidate and impact the vision in the long term, but I rarely use them, especially in the placoid form. So thank you very much for Yanni for this case, and if there's any questions at the end, we'll take it, or comments.
So thank you, Dr. Yanni and Dr. Francisco. So with this, we now move on to the third set of our case presentations, and now this time is an atypical case of ocular syphilis. For this, we have Dr. Mudit Tyagi from LV Prasad Eye Institute, Hyderabad, India, and his fellow, Dr. Shravya Chaudhary Bala, will be presenting the case.
Yeah, thank you so much. So the case, Shravya, can you in the meanwhile share your slides?
Sharing my slides.
Yeah, so we wanted to show a very atypical, unusual case of syphilis that we came along, and I'll let Shravya present the case first, and then maybe we can all have a discussion on that. So Shravya, you can start, please.
Hope I'm audible.
Yes, you are. Your slides are visible.
I would like to thank IUSG for giving me this opportunity to present this case. I'll be presenting a case of atypical ocular syphilis, and the session will be moderated by Dr. Mudit. So our patient is a 23-year-old male who presented to our OPD with a 3-day history of diminution of vision in the left eye, which was acute in onset, painless, and progressive. There was no past systemic history. On ocular examination, right eye had a best-corrected visual acuity of 20/160, and left eye had 20/20. Slit lamp examination of both eyes revealed a quite anterior chamber and otherwise unremarkable. On examination of the fundus in the right eye, the media was clear. There was a cup disc ratio of 0.3:1. There were 2 large granulomas in the peripapillary region, one above the disc and another inferior to the disc, with some dot and blot hemorrhages, and multiple areas of healed chorioretinal patches in the posterior pole along the superior nasal and inferior temporal arcade. These scars were subvascular. The macula had an absent foveal reflex and macular edema. This clinical picture led us to suspect a diagnosis of ocular tuberculosis. OCT through the macula showed that there was hyperreflective dots in the vitreous, suggestive of vitreous cells. Intraretinal and subretinal fluid suggestive of cystoid macular edema. OCT through the granuloma revealed elevation of the choroid with some amount of subretinal fibrin and involvement of the inner retina. So this is the autofluorescence of the same patient, showing areas of hypoautofluorescence suggestive of healed choroiditis and areas of activity in the superior nasal and inferior nasal quadrant in the right eye. Left eye was essentially within normal limits. And at this point, the clinical picture was suggestive of ocular tuberculosis. So we sent for an MON2, which returned strongly positive. ESR was mildly raised and HIV was non-reactive. HRCT suggested of small mediastinal lymph nodes and opacities in bilateral lower lobe of lung, which kind of confirmed our diagnosis of ocular TB. However, much to our surprise, both VDRL and TPHA were positive. So as we all know, that non-treponeural tests like VDRL correlate to disease activity and generally become positive 1 to 3 weeks after primary lesion. On the other hand, treponemal tests remain positive regardless of treatment or disease activity. The point to remember here is that TPHA and VDRL have a very high specificity of around 95% for ocular syphilis, but TPHA also has a sensitivity of more than 94% to detect cases of ocular syphilis. A review of literature revealed instances of ocular syphilis presenting as choroidal granuloma, which have been published. And since syphilis can be such a masquerade and with highly sensitive and specific VDRL and TPHA, a presumptive diagnosis of syphilitic choroidal granuloma was made. And therefore, instead of starting ATT, we started the patient on injection crystalline penicillin, 24 million units IV for 14 days. After 10 days of IV penicillin, the lesions had completely regressed and the best corrected visual acuity improved to 20/80. And this is the OCT showing few hyperreflective dots in the vitreous. We can see that the cystoid macular edema has completely resolved and the granuloma also completely regressed, and there's features of scarring. So this image demonstrates a clinical picture at presentation and note the decrease in granuloma size on OCT from initial presentation to the 10-day follow-up. 2 months later, the patient's vision improved further to 20/30 and he had no further recurrences. So the take-home message from this is that ocular syphilis can be a grade masquerade and can have atypical presentations, should be considered as a differential in all uveitis. TPHA has high sensitivity and specificity, and ocular syphilis is treated on the lines of neurosyphilis, with IV penicillin being the treatment of choice.
All right. Thank you, Shravya. Can you just go back to the initial clinical image that you had shown? The first one, yes. The prior one. Yes. So thank you so much. So the reason we wanted to show you this case was because this was such a surprise to all of us. The moment we saw this patient with these extensive granulomas, both superior and inferior to the disc, subvascular pigmentation, areas of healed choroiditis, some areas of active choroiditis, and with that OCT also suggestive of the granuloma and the macular edema and the inflammation, with a strongly positive MON2, our diagnosis was nearly tilted in terms of this being a case of tuberculosis. But like what we discussed earlier, like what has been discussed and shown in the previous cases, we do consider syphilis to be a differential for every single case of uveitis that presents to us initially. And as a rule, all patients are screened for a serology of syphilis whenever they are seen at the retina or the uvea clinic. So this patient also underwent a TPHA as well as VDRL, and to our surprise, TPHA came positive. Now, because syphilis can be a masquerade, we initially, instead of giving the patient ATT or anti-tubercular therapy, decided to give the patient a trial of penicillin. Also, one strong point in favor was the such a strong TPHA positivity and high titers of VDRL. And within a week, we started seeing a complete response. At 10 days, in fact, the visual acuity had improved to 20/80. Most of the lesions had completely regressed. Even on OCT, we could see an entire absolute flattening of the granuloma. And by 2 weeks' time, the lesions had completely gone away. The visual acuity was around 20/40. When the patient came back at 2 months visit, and after that, we did not have to give any other treatment to this patient. The patient's visual acuity was maintained at 20/30. So this was actually a case of syphilis, which was presenting with features which were absolutely mimicking what would otherwise have been labeled as an ocular tuberculosis. So our main essential take home, like what has been told earlier, is to consider syphilis as a differential in each and every single presentation of uveitis, and to rule it out first because of its absolute ability to mimic manifestations of all of the known uveitis that we can think of. That's it from our end.
Okay, may I ask a question?
Yes, Professor Westcott. Yep.
I certainly, if you look at this color picture, I mean, there does seem to be granulomatous disease, but if I wondered if you did a careful OCT, if you had the technology, just kind of within the inferior arcade, I reckon you would have seen changes more in keeping with the placoid syphilis. So that I think this patient is clearly got syphilis, but he's got syphilitic choroidal lesions and also the syphilitic placoid, which is choriocapillaris, maybe it's these weird sub-RPE conoid things, which I've never seen in TB, but I'm just wondering, I think Francesco would have loved this case for his multimodal imaging. I'm actually skeptical about it. I mean, multimodal, it's fine, but the blood test will tell you the problem. But But
So
I'm just
we did end up doing serial OCTs through all the lesions. We just have not shown it in this presentation, but we did OCTs through the lesion which was inferior, also inferior to the granuloma. There was no other sign of a placoid chorioretinitis, which we would otherwise have seen.
fair enough.
And the OCT through the lesion was absolutely like that for granuloma. You could see a coronal elevation over there with subretinal fibrin also, which was there above that. So all the features actually were very much suggestive of a granuloma. In terms of the subvascular pigmentation, we actually have seen quite a lot of subvascular pigmentation in TB. In fact, we have published it as one of the signs of TB vasculitis also, a subvascular pigmentation. So essentially, clinically, when we had seen this patient, our diagnosis was that we are dealing with granulomatous coronal granulomas. And even the MON2 was so strongly positive, 30 millimeters. Our initial diagnosis was ocular TB. We did get scans through all of the areas. We did not find any placoid chorioretinitis, neither at the macular area nor inferior to the lesions. I think Francesco has actually seen this case once earlier. We had in one of the meetings, probably when we had met, I probably had shown this case to him once when he was visiting LVPI.
Yeah, it's a perfect case because to call atypical syphilis, definitely.
Thank you.
Dr. Tyagi, this is a beautiful case. Thank you so much. I have a question. This patient did not have TB at any point before, so always tested negative for TB test, right?
So the patient's chest scan actually did show signs of atelectatic lesions and some old fibrosis at the lung. And India being endemic for tuberculosis, you never know. The MON2 was also positive. But clinically, we discussed it with the pulmonologist. He said he doesn't see any signs on the radiology which are suggestive of any active pulmonary tuberculosis.
Interesting, yes. Thank you. I have another question, just a general question, Dr. Bensal, if you may allow me. With testing for syphilis, if you have a patient with anterior uveitis, do you test them? I mean, we usually not test patients with anterior uveitis with non-revealing history for anything, but do you recommend in this current time and age to test everyone with anterior uveitis for syphilis, maybe syphilis only? We don't do that. I'm just interested to know your opinion. Or recurrent anterior uveitis only for syphilis, or the yield is too low and don't do this. I don't know what people do.
So thank you, Dr. Salam, for this question. I will leave it for the panel to discuss. It's open for the panel for the controversies. But I would like to answer that yes, we do syphilis testing in all patients because, these surprises can come up anytime. And the best case is Mudit's case where, thinking of syphilis was the least, would be least in anybody's mind. So TPHF for us is, it's one of the basic testing for any kind of uveitis, unless the clinical diagnosis is written on the face. So yes, any non-specific anterior uveitis, we do rule out. And can I take up now questions? We have some questions in the QA section, and seeing all the cases, wonderful cases, and listening to the discussants, we have a couple of questions. Dr. Salam, you said you have a lot of syphilitic cases there, about 10%, you said?
Yes, we have lots of syphilis cases
So
here.
anything to differentiate between their clinical presentations and their outcome responses when it comes to HIV versus non-HIV syphilis cases?
I mean, I think treatment. We see is that their treatment, their risks of reinfection, we see that the risk of reinfection is high. So I think something to be wary of. And there was a question in one of the questions here about treatment with local steroids. And I think you have to be careful with local steroids. We do use them. We do even go to intravitreal steroids for cases of cystoid macular edema post-syphilis that does not respond to anything. But I think something have to be careful of make sure that they have responded well to treatment with a decrease in titer by fourfold, and also not reinfection, because especially in the HIV patients, we see that reinfection is common. So that's one of the things we see as well.
And coming to the use of the titers, how frequently? This question is there in the QA section, and
yes,
an answer as 4 weekly. But is that what we all follow? I mean, this is open for all the panelists. how frequent we do monitor with VDRL? So how frequent? Dr. Westcott, what would you recommend? How do you do in your practice?
Yes, probably 4 weekly. I mean, I tend to leave that to the GU physicians, to be quite honest. I mean, someone mentioned how long you treat these patients. I mean, I send them for the neurosyphilis protocol, which means 2 weeks of IV or the IM, whatever. I've never had to give them more prolonged antimicrobial therapy for eye disease. Maybe we don't know how long you've got to treat for eye disease. Very rare. I've had patients who've had persistent edema, and we've worried about the penetration into the CSF, and we've questioned whether we do a tap, but the patient eventually got better with a lot of topical steroids. I don't worry too much about the normalization. I mean, I will get titers done 3 or 4 weeks later at the physician's discretion, but I think as ophthalmologists, I tend to leave that to the physicians. And also, we're awful at asking questions about reinfection. I don't know about you, but we get pretty embarrassed about these things as eye doctors and asking, you have to have a suspicion, but again, you'd hope that the GU physicians would perhaps be more skilled at asking those kind of questions about reinfection and things. So I don't use the titers as I mean, I like to see them go down, but I don't use them for ocular to assess whether the eye's getting better, because the eye just gets better. The other thing I would note, I mean, we've presented some fascinating cases, but it's a remarkable disease how much of it can normalize. I mean, I'm just pointing this out for the residents that if you have an idiopathic, non-infectious pan-uveitis, God forbid, a Behçet, you'll never get normalization of structure, but you could have terrible pan-uveitis from syphilis. You can give them the full treatment, and 6 months later, the eye looks almost normal. I mean, maybe a bit of RPE change, maybe a bit of pallor, but quite extraordinary disease. I can't think of anything else that can do that very well. Maybe Lyme disease or something, but this is just an observation how much of the structures can, if it's caught early. Of course, if they present after 4 months and they've seen 5 other specialists who've missed it, then that's bad. But if you catch them early, you can normalize it. Nothing else will do that pretty well.
Francesco?
So regarding the RPR, it depends, I think, where you practice and how often you relate to your infectious disease specialist. So I'll give you an example. When I was in Cleveland, for example, where I think it's the syphilis hub for the US after maybe San Francisco. So the ID specialists, they're so used to having patients admitted just for eye disease that they know how to treat. They know it's neurosyphilis. So they follow their own protocols. And yes, we are not the ones who should repeat the RPR. When I came here in Abu Dhabi, the syphilis rate is actually going up here as well. And it's not because I came here. The infectious disease specialist is not so used to handle an infection just limited to the eye. So they ask us a lot of questions. So in this particular case, for example, I repeated the RPR, and we sat with the infectious disease specialist who said, listen, let's give him a couple more days. We did, I think, 7 or 10 days of doxy and repeat the RPR, and it did normalize. I think it's a matter of where you practice and how familiar your infectious disease specialist is with infections just limited to the eye.
Okay, so coming to the biggest controversy in ocular syphilis, the use of oral steroids. So from what I've seen here amongst the cases presented and by the talk by Dr. Westcott, he said he starts the steroids maybe a day earlier or at the same time. Dr. Salam said he gives a short course, 40 milligrams for 2 weeks. From Mudit's case, we saw that I think your case was not given steroids, just treated with penicillin with a great outcome. So can I have the panel's tips for the attendees? Because there is a lot of confusion whether to give steroids and how long, when to start, when to stop. We'll start with Dr. Salam. Yours is clear, I guess. 2 weeks of
Yes, yes, we do this routinely, 2 weeks of steroids. I think the important point, and I don't think there's really an issue is that, because if you're giving them antimicrobial treatment, steroids should not like aggravate their inflammation. I think the issue is reusing the steroid if you have a case, and most of the cases do respond, as Dr. Westcott mentioned. But if you have a case not responding well to treatment in terms of persistent inflammation or persistent CME, before, I think in this case now, before jumping to give steroids again, or even go down the routes of local steroids, I think that's where you have to check that the patient was well treated and there's no reinfection. I think that's the important point in my view.
Okay. Mudit?
Yeah, so what we have seen is that most of these cases do not need steroids. The inflammation that we see also goes away with penicillin. So it's like syphilis responds miraculously to antibiotics. And even in a case of placoid choroidititis, in cases where we have seen vitritis, in I think except for 2 cases that we now have a data of around 110 cases till now, and we have had to give steroids only in 2 cases essentially. Otherwise, everybody, even the vitritis, regresses. Occasionally, once you have treated the disease a month or 2 months later, you see still persisting vitritis. That is actually more of a debris which can be taken care of by doing an optical vitrectomy. Your disease has predominantly healed. Now you just have got some old debris and vitreous floaters which are there. But the disease responds very well. In most cases, you don't need to, that's what we have noticed. You don't need to resort giving them steroids. The only indications occasionally can be a worsening, a gerish eczema sort of a reaction. But again, I do not have an answer to why this happens, but we do not see that much of a gerish eczema sort of a reaction or a worsening after we initiate penicillin for our patients. One more paradoxical consideration that we need to keep in mind sometimes is that some of these patients are HIV positive patients also. Their cystoid macular edema that you are seeing can actually be a manifestation of an immune recovery uveitis that you are seeing. So it becomes important for us to get the CD4 counts tested before we are thinking of initiating steroid therapy for them. But for most of our patients, what we have noticed is that we have fortunately not needed to resort to giving steroids. They just respond to penicillin itself.
Dr. Vishali, ma'am, your experience?
No, I think we all understand there is no consensus, and it is your comfort level and the way you manage patient. And from our experience, we have also seen that few things work in one region and the same may not be working in another region, you know. So it's very important to have your own experience. But what we learned from this, and I don't think Dr. Westcott said that he uses steroids in his practice. He just said, oh, we have the Shera, sorry for the fireworks. If you have, he just said to avoid Harish eczema reactions, ID specialists treat with steroids followed by IV antibiotics, penicillin. He did not say use it as a routine. So I guess all of us are very comfortable starting antibiotics first, adding steroids if you want to. The indication personally for me, every time I see disc edema, severe vitritis, pan-uveitis kind of a picture, I add steroids. But then we will have to reach consensus later on. It's a good point to study. I was just wondering, for IUSG to reach expert consensus about steroids. Local steroids is another issue. So I don't think we are right now at a position, and Mark Westcott will take a lead and take it forward, maybe by next year.
Yeah. Can I just add one point here, Dr. Rima, with your permission?
Yeah, please go ahead.
Yeah. So I think one common thread among everything, what Professor Westcott said or what Dr. Salam said, and what ma'am is also saying, I think the one consensus essentially to ensure whether we treat with steroids or not, a golden rule is that we have to treat under the cover of antimicrobials. This is what Dr. Salam also said, Professor Westcott also. I think that's the message which has to go to everyone, that even if you intend to start steroids and you're monitoring your patients carefully, fair enough, but absolutely essential to ensure that it's under the cover of appropriate antimicrobials. And then everybody can take a call basically based on the response of the disease and how it is evolving. But that baseline has to be there, the cover of appropriate antimicrobials. And I think that's a rule which applies to all infective retinitis, not just syphilis.
So thank you, Mudit. So now we come to the imaging part of it, because many times we have this ground glass syphilitic chorioretinitis and the diagnosis is written on the face. But Francesco, with your lot of work on imaging, would you like to just highlight some of the OCT biomarkers where you would like to tell the attendees that if you see these points on OCT in a case of retinitis, just think of syphilis and probably rule out others?
I would start with the placoid form. As Dr. Westcott mentioned, those nodularities of the RP, they're super typical. So in the paper we published ages ago now on and collected cases of placoid, we showed that the patients, if they show up in your ED very early, they have some subretinal fluid in the first couple of days that goes away on its own, and then they develop those nodularities. And those nodularities, as was mentioned before, maybe they can make you think of lymphoma, and you should exclude it based on the age of patient and some other factors, but they are very, very typical of syphilis, especially if you see those white plaque. Talking about the periphery, the ground glass appearance, the OCT sometimes highlights, as Yanni showed, those hyperreflective deposits on the posterior hyaloid or on the retina, but these are a sign mostly of infection. They're associated also with toxo, so they're not super typical of syphilis. They are just typical of infection. So overall, I'm very surprised by Mudit's case, because syphilis to me is not a disease of the core, right? The spirochetes probably are coming through the choriocapillaris, but it's a disease that mostly affects the retina. So I would concentrate on those nodularities, which are very, very typical of syphilis.
Okay. Anything on the autofluorescence which just clinches the diagnosis? Maybe the patient presents in a very early stage, but if you happen to do autofluorescence and there you have like a placoid kind of hyper autofluorescent halo, a huge halo. So would that be the clinching?
Yeah. So so Dr. Westwood showed a beautiful OCT with the attenuation of the ellipsoid in the placoid form. So since the ellipsoid are attenuated, you are just seeing more of the underlying RP autofluorescence. So the whole plaque is hyper autofluorescent. So it's very, very typical. So even if the plaque is very faint on examination, doing autofluorescence can help you highlight where exactly is located and give you an idea of what's the diagnosis.
Okay.
I would also like to add the fluorescein angiography. On fluorescein angiography, the pattern seen in AMPI, serpiginous, and syphilitic placoid are very different. AMPI, you have multiple lesions, hypo, hyper. Serpiginous, you have a single lesion. The edge is hypo, hyper, with the dye getting into the adjacent healthy retina, whereas the center is kind of mixed fluorescence. Now, syphilis shows very beautiful placoid. The whole lesion becomes ground glass, and it's a very low intensity hyper. It's not really hyper like the edge of serpiginous. So the whole lesions uniformly becomes ground glass kind of in the late phase. So that also, though we don't, talk much about angiography these days, but this is still very classic.
I think I would like to add to ma'am's point in angiography. The case by Francesco's fellow, Dr. Yannis, I think the fellow eye also did show some bit of hyperfluorescence on the fluorescein, the normal fellow eye. So it was asymptomatic, but sometimes we see that even in our own experience with unilateral cases, the asymptomatic fellow eye also shows some changes on the autofluorescence and even on the fluorescein, maybe in the periphery. But if we pick it, that we pay attention, they are there.
Dr. Banta, can I add something very quickly?
Please.
Sometimes in the periphery of the other eye, because syphilis is a bilateral disease, you can see also like a fine pigmentation, something like a sectorial retinitis pigmentosa picture. And I think that, again, in the context of uveitis, is a picture that we know that can happen in syphilis. So might be a patient presenting with this eye with a pattern that you're not sure what's happening, but then the other eye you see this, that can also make the thinking of syphilis because you can get that pattern of pigmentation.
Rima, if I might, there are a lot of questions related to
Yes, ma'am.
Mudit's case and
Yeah,
how to differentiate a choroidal granuloma of syphilis from TB. I think we need to highlight that what Mudit has shown is not a very common scenario, and we don't expect them to start treating for syphilis in patients of choroidal granuloma because it's extremely rare for syphilis to present as a choroidal granuloma. So that is just like Ahmad is seen so many cases, Mark, Francisco, including Mudit, they are all pioneers of syphilis. So what Mudit is showing, once in a lifetime case,
Exactly.
that is not for following in the practical management.
Yeah. And if I may add, clinically, this looked absolutely like a TB granuloma. So this is not, you
We
do.
never know. We never know. Mudit TB might come back 5 years down the line. So,
Absolutely. Yeah.
so let's,
So that is why, so you cannot differentiate on the basis of clinical features. The reason we actually even came to a diagnosis of syphilis was basically just because of serology. And what our take-home message from this case was not like what Dr. Vishali ma'am is saying, not to treat granulomas with penicillin. Our take-home message is essentially this case highlights the fact that you need to have syphilis in your index of differentials, and it can end up surprising you. So you should get a serology for syphilis TPHA done for all cases. In this case, because it came positive, we treated this patient on lines of syphilis. But like what ma'am is saying, this case does not mean that you take back a message that you start treating granulomas with penicillin. No, we treat them based on our etiology and whatever we have diagnosed them with. This was a very rare, very atypical, very unusual presentation of syphilis that we came across, and something which we have never ever seen after that in any of our cases.
I must say, I've never seen it myself. I've seen 25 years. So it's a very, I think we're getting sidetracked about the syphilitic granulomatous disease. It's very, very rare if it is, but it can do anything. But for the attendees, it's a rare phenotype.
Yeah, the most common ones that we need to remember are the placoid chorioretinitis. That's the one, the ground glass retinitis. And the one more pattern was which Francesco has also shown in one of his slides, the one which comes with small multiple miliary lesions. And if you do an OCT through them, you will find a full thickness retinitis that is there in those miliary lesions. And if Francesco can probably add, like what we had discussed, these are the ones. Yeah.
So those miliary lesions that you're talking about is the multifocal inner syphilitic something, and it was described, I think, by Andre Curie and Saraf some time ago, and is typical of misdiagnosed syphilis and treated with steroids. I actually have never seen it, thank goodness. But there's a couple of papers out there, and it's a full thickness retinitis that is look like it's multifocal, meaning it's in multiple foci, and it's a sign that some misdiagnosis happen.
Okay, so there was another question of anterior uveitis, which Professor Westcott has answered.
Rima, just for a second, Somya has put a nice reference on Q&A where he's shown that penicillin acts against Mycobacterium TB. So Mudit, we still need to see whether your case, a couple of years later comes back and you may have to give ATT. But I think that's it.
Yeah. 3 years down the line, still no ATT, but yeah, you never know when he'll come back.
His HIV was negative, right?
Negative, yeah. Me and Dr. Basu keep on banging our head on this case.
Head,
So you
Rima,
need a
sorry to
long follow-up for this.
Yeah.
A few questions are there in the QA section, if you can just answer them.
Yeah.
There are a lot of confusion. I think, Mudit, your case has solved that, some people are asking about the extra pulmonary TB infection. But right now, in this case, I think it's not the priority.
Yeah.
Even if it is a latent infection, not a manifest infection, I think we would just watch it.
Yes.
And what ma'am is answering the other question about core vitrectomy for a patient who persists with dense vitritis post-treatment. So, Another question would be, a lot of people have asked, and I think we have discussed about the choroidal involvement. So this was just one case by Mudit. Anyone else who has seen a case of stromal involvement in syphilis in your personal listing? So I did recently see a case of bilateral choroidal multiple granulomas, like, something like a sarcoid, maybe an early VKH disease. So I'm yet to follow up. The patient tested positive for syphilis. So maybe I'll be happy to share the outcome in another meeting or so. So that was again a surprise. So it's not always retinitis or an infectious etiology. I mean, I think we should pay attention to the choroidal involvement. So any other point?
So, Rima, if I may, I think it's a very good point about the choroidal involvement. So if we think of the placoid, for example, why is it happening at the level of the macula? Because probably the spirochetes are coming through the chorocapillaris or the choroidal flow, and that's major at the level of the macula, right? So probably they're coming through there and then infecting the RPE and the retina. So the choroid is surely playing a role. It's not a major role like we see, for example, in other infectious diseases, but we need to keep an eye on it and an open mind.
Yeah. And any role of anti-VEGF therapy for refractory syphilis with cystoid macular edema? There's another question in the QA section.
Not exactly. I think, like I said, one more thing which you have to consider when you think of a refractory CME is to ensure that you have ruled out an immune recovery uveitis if your patient is also HIV positive. But anti-VEGFs usually not much of a role. You probably will need to either start your patients. They refractory CMEs, again, probably that can be one indication where you can initiate systemic steroids under the cover of doxycycline if you need to. But again, the first and foremost point which I will consider is ruling out an immune recovery uveitis. Get the CD4 counts tested. If needed, steroids under the cover of doxycycline for a month if you have already treated the patient with penicillin earlier.
And another question for you, Mudit, by Dipankar, about the granuloma in the retinochoroid. Could be a gamma, which can be seen rarely, and they're seen in the late stages of syphilis and not really in the early stage. So any comment from you?
A possibility, I mean, there are till now only 3 or 4 cases of syphilitic granulomas. One of them is this case actually, and 2 or 3 more other cases. So this can be a possibility, but like this is the only time we have seen such a presentation. So difficult to comment upon them. There can be a possibility of that. True.
Okay. So any more tips?
Can I just say one thing about the edema? I mean, chronic macular edema post-treponemal disease. I mean, if the patients had full penicillin therapy, the 2 weeks of IV, and they just happen to have a chronic macular edema, I mean, it's usually in one eye. I suppose if it's bilateral, I wouldn't have a problem using oral steroids as long as they don't have HIV and immune recovery disease. I wouldn't have a problem using Ozurdex. I mean, I would typically use topical steroids first and Ocular or non-steroidals and probably get a response. But I don't think you have to worry about reactivation of a treponemal disease in the eye. I mean, we worry about that with ARN, possibly and unnecessarily. We worry about that in toxo, but these are very different. Syphilis is a blood-borne disease, and if you marinate the whole organism, the whole body in penicillin therapy, giving neuro doses, you should eradicate every spirochete anywhere. So I would have no problem using Ozurdex. I think we have used it maybe in 1 or 2 cases with chronic edema, and I think that just occurs because the blood aqueous barrier has just been devastated, but probably because of late presentation or perhaps inadvertent steroids pre-diagnosis. And someone gave a question about poor outcomes. If you want to make your patients do badly, give them steroids for a few months before you make the diagnosis. I mean, we've all seen horror stories of delayed late diagnosis, and these patients do incredibly badly. You get uncontrolled spirochetal proliferation. Patients become very sick. You can kill them, so they don't do too well if you if you're missing the treponemal disease and you're just giving them steroid monotherapy. But anyway.
Yeah.
I totally agree to that. Even in courts, we found the patients who did badly or had poor prognosis were the ones where initial diagnosis was missed. They were treated with steroids, they were treated with immunosuppression, and if they were treated for steroids and immunosuppression and not given anti-infective for more than a year, they had extremely poor prognosis. So what Mark is saying is the key lies in starting the anti-infective therapy, and once you have treated it adequately, steroids is not an issue. The problem is you're giving steroids without making the diagnosis. Or if you're not sure it's viral, toxo, whatever, or syphilis, if you're not sure, then please do not introduce steroids and get a referral to a higher center.
We have another question about the use of antibiotics in patients who are sensitive to penicillin, especially in pregnancy. So the comment from the panelists, your choice.
I think I covered that in my slide. I don't know if we can put it up, but you're going to speak to infectious disease, but you can give ceftriaxone. And the thing about penicillin allergy, you've got to be careful what type of allergy it is, what type of sensitivity. Older penicillins, the modern third generation cephalosporins would be very unlikely to react severely in patients with penicillin allergy. So speak to infectious disease. You can always do desensitization if you want. It's quite laborious and slow and expensive. You can do a single test dose with ceftriaxone before you give it. So there are many ways around this. You're not going to give doxycycline. I agree with that. But infectious disease will help you out here. But in reality, I think it's less of a problem. My understanding is third generation ceftriaxone is CDC recommended for penicillin allergic patients, as the risk of cross-reaction would be pretty low, and you can do a test dose anyway. If they react to that, then I can't give you an answer. But...
Okay, and I think I will just take up one last question, which is by me to all the panelists. So sometimes we do see a case of syphilis where we send to the ID specialist for their opinion and for starting the treatment. And at times the patient does not have any skin lesions or genital lesions or anywhere. So the ID specialist says there is nothing in the body. We do not recommend giving treatment. And this has happened when the patient has already been treated for syphilis in the past. So how do you treat? Like for us, I mean, we just directly start with maybe penicillin or ceftriaxone for 2 weeks, and we are helpless because the ID specialists do not support us at this time. So how do you go about it? And I'm sure many among the attendees also must be facing this challenge. So rather than dilly-dallying the treatment, you have to save the eye. So would you recommend we just start off on our own?
Yes.
Yes, for me, if I am convinced it needs to be given, nobody can stop me. Once I know that I don't have
I wanted this message to be conveyed to all our attendees because, this is where the dilemma comes. So when we see syphilis, we are convinced the tests are positive. There are no other signs in the body or the skin lesions. I think we should go ahead because these drugs.
Only thing, Rima, don't give that prophylactic single dose thing. That is important. Even if you are giving it without any systemic, it has to be treated at neurosyphilis. And second is get the partner treated as well, because otherwise there would be.
Yes, thank you, ma'am, for bringing this point. We haven't touched this point. So for all the attendees, important to get the test for the partner done. And then do we refer the patient to the ID specialist, or do we?
Do.
The patient does not have any symptoms of eye. The partner does not have any symptoms of skin. And convincing the partner to go have treatment, it's quite difficult. But then that partner needs counseling by the ID specialist.
Rima, can I add something
so
here?
If I may, Rima, sorry.
Please go ahead.
So just so this comment, Rima, is very important. So it also goes back to when you practice, when you move, when you practice in a different place, you need, first of all, to establish a good relationship with ID and rheumatology. So raise awareness about, for example, about eye disease, is infectious just limited to the eye. Go to their grand round, present cases so that they are aware it's happening. And once you have established a good relationship, it's very rare that the scenario that you just proposed really happens. So it can, of course, but whenever you move to a different place and you're a uveitis specialist, it's very, very important to network.
Yeah, I would just like to echo this. And I think you can treat like one patient yourself, but there are lots of implications of treatment, especially if you're going to go on and treat the partner yourself. I think there are lots of social issues. And what if they get another infection? I think it's like out of our area a little bit. So I think, yes, you have to insist on your opinion, but I think communication is the key, and connect with them, get them involved in your papers. And I think then you have the resistance would be less. So I think
Partners
that's
are treated with ID, not with us. Yeah.
Yes.
yeah. So I think it just I think communication, and also like sometimes if you talk to them through emails or you know through your Epic, it doesn't work. So just you know get them on the phone and speak with them or go and talk with them, and that usually works.
So I think with this we are done with the queries and the controversies.
The next one would be on viral anterior uveitis. I don't exactly remember the date. I think it's 10th or 12th of November, but we will of course send. And for all the attendees, for CME credit hours, please complete your form and send it to the email, and you will receive the certificate about CME credits. So is John there? So yes, I would let John to conclude, but reminder for Inflammatio 20 to 21st November at Singapore. The registration is open and we are already close to 200 registrations. So there is a basic course on imaging a day before, and then there is a consensus multimodal imaging in uveitis, which will focus on what should be the minimal imaging. It's not only minimalizing investigations, it's also using the imaging judiciously and minimalizing it. So this would be an interesting forum for all of you interested. Please come and join us at Singapore. Over to you, John.
Great. Well, thank you everyone for coming. This was a very interesting course. Like tuberculosis, you know, it's really evolved to where we can be much more specific in recognizing strongly suggestive patterns, although we continue to screen everyone for syphilis that presents with at least bilateral or chronic uveitis. So thank you all, and we'll look forward to seeing you next month. And thank you for all who participated.
Thank you.
Thank
Bye.
you, everyone.
Thank you. Thank you, everyone.
All the panelists and the
Thank you,
case.
everyone. Thank you so much.
Thank you.
Thanks
you,
to
Alejandra.
organizers.
Yeah, thank
Have
you.
a good weekend.
You all have to send your cases to Alejandra. She's compiling a book about the grand rounds. And please make practical tips, the tips which they can't find elsewhere.
Sure.
So
And,
thank you.
and the PPT formats to be sent to Alejandra.